So one of the things that I specialise in are disorders affecting hips in young adults, and these conditions can present in many ways, but we typically see a lot of young sportsmen who present with groin pain, and there can be a lot of confusion as to what causes this groin pain. So some of the terms that people have used in the past are things like Gilmore's groin or a sports hernia, and those are conditions more to do with the soft tissues at the front of the abdomen rather than the hip joint itself. But there are conditions that affect the hip itself, and particularly in sports people. So everybody knows about cartilage tears in the knee, but you can also get cartilage tears in the hip, and often these conditions can happen as the end result of a long process. So people can start to build up issues with their hips, even as early as in their teens, and then they feel the effect of this much later on. So they can start to present with symptoms in their early to mid-20s, or even much later on in their 40s. And all these conditions come under a broad spectrum of conditions, and at one end of the spectrum there might just be something that people would think would be a groin strain, and at the other end of the spectrum it would be full-blown arthritis in somebody who's hopefully significantly older, who might then need a hip replacement. So a lot of young sportsmen will notice that they get pain, particularly when they're being active or after they've been active, particularly if they're doing a lot of activities with the hip flexed. So we often see people who are footballers or rugby players or even hockey players, but we can also see quite a lot of triathletes who come in with these sort of problems. And it's unremitting pain in the groin related to activity, and particularly with any sort of twisting activities. And sometimes, unfortunately, these conditions go unnoticed for a long time, so patients can go on to their GP who don't quite understand what's going on, and so they can be given sort of courses of medication or even be sent off for physiotherapy, and the condition isn't fully recognised until much later. So really the first role for us is to try and identify what's going on, and we can confirm whether it is one of these conditions by getting a combination of x-rays or MRI scans or even CT scans, but also obviously by examining the patients and making sure that we can identify the source of their pain. So is the pain really from the hip? Is it from the soft tissues around the groin? Is it from further back in the pelvis, or is it from their back? Because all these things can give you crossover symptoms. So it can sometimes be quite difficult to unpick the source of the pain. But the key thing for us, I guess, is once we've identified what's causing the pain, how we can help patients. And not everybody needs an operation. There are things that can be done. Some people can be significantly helped by physiotherapy so that they can get appropriate conditioning of the muscles around their joint. Other people can be significantly helped by an injection into the joint or an injection into the muscles around the joint if there is significant inflammation in that muscle group. So the percentage of people that then go forward for surgery is of course a much smaller percentage than those that have these sort of symptoms. And so it's important to pick patients carefully if we are considering them from surgery, so that we can be realistic in what we can achieve. And as I mentioned earlier, one of the key things really is if you've got a labral tear, which is the cartilage tear that you can get in the hip, we know that these tears don't really heal, and so they will continue to give symptoms, particularly if people are continuing to be very active. And so if somebody wants to maintain a high level of activity and be a sportsman, then they'll continue to have symptoms unless we are able to do something to help them. And probably the most helpful way for us is to do keyhole surgery in the hip, so that's what's called a hip arthroscopy. And with that procedure we can look inside the hip joint with a telescope. We can confirm what the problem is that's giving the person pain, and then do something to try and improve things for them. So that if they do have a tear of the cartilage, we can usually repair that. Sometimes when it can't be repaired, we can even replace the cartilage. If there are loose bits inside the joint, that sometimes can happen, we can remove the loose bits. And the other thing that we can do is to reshape the ball. The hip joint is a ball and socket joint, and one of the problems that can occur is that the ball becomes misshaped, and so we can go back in and reshape the joint so that it can glide more smoothly and then give less symptoms. The operation involves coming into hospital and having surgery, so we often get people to come in first thing in the morning so that they can be prepared for surgery. The operating time depends on what we're actually doing, so it could be anything from an hour to 3 hours, depending on how complicated the procedure is and how many steps we have to take to achieve the desired outcome. But typically patients will then go from the operating theatre to a recovery area and then back up onto the ward. We can usually get somebody to stand up pretty much straight away with the physiotherapists, and they'll be shown a list of exercises to do and shown how they can get the hip moving again. Quite often we'll get patients onto an exercise bicycle before they leave the hospital, and we arrange for them to have physiotherapy and often even hydrotherapy, because exercises in the water are very helpful in getting the hip moving again. The hip can be painful after surgery, and obviously we do give medication to help with the pain. We also use infiltration of local anaesthetic and some other drugs to try and reduce the pain in the immediate period after surgery. And encouraging patients to move the hip and keep mobile often is enough to keep the pain under control. Typically, people will be able to return to work after about 2 to 3 weeks, but they can get back to driving within about 2 to 3 days. There are some procedures that we do that are a bit more complicated, and we then have to keep patients from putting all their weight through that leg, and so they may need to stay on crutches under those circumstances for a period of up to 4 weeks. So obviously they won't be able to drive or go back to work during that time. But the vast majority of the patients we carry out this type of surgery for will be back at work after about 2 to 3 weeks. Well, Circle is a fantastic place for patients. I think all patients love coming here because it's such a great environment. We have all the state-of-the-art equipment available to get people safely through their surgery and comfortably. And I think patients enjoy the experience here. So there really is no comparison with any of the other hospitals in the area.